autoantibodies also causes follicular cell hypertrophy and hyperplasia, which can lead to a diffuse, non-tender enlargement of the thyroid, or goiter. Remember, this is in spite of a low TSH level. Contrast this with Hashimoto's thyroiditis and endemic goiter, in which hypothyroidism causes increased levels of TSH. In these disorders, it's TSH that's causing the gland hypertrophy. All right, in addition to the signs and symptoms of hyperthyroidism that we already covered, there are two more symptoms that are specific to Graves' disease. The first is Graves' ophthalmopathy, which manifests as an impressive bulging outward of the eyes known as exophthalmos. Why does this happen? Well, interestingly enough, orbital fibroblasts express TSH receptors. Anti-TSH receptor autoantibodies bind to these receptors to promote tissue remodeling, fat deposition, and inflammation. Notice that on the side of the goggles, we've incorporated an antibody design. There's also local helper T cell activation, leading to cytokine release. Think of his little sidekick helper dude as a helper T cell, holding that cytocoin ransom money. Cytokines stimulate fibroblasts and adipocyte activation, resulting in an increase in the number of adipose cells, as well as increased production of glycosaminoglycans, symbolized here by that glycosaminoglycan GAG. These glycosaminoglycans, mostly made up of hyaluronic acid, are extracellular glycoproteins that love grabbing onto water. They pull water into the orbital space, which causes swelling of the extraocular muscles and retroorbital tissues, displacing the eye forward like it's going to pop out. Swelling of the extraocular muscles can even impair their movement, causing visual changes such as diplopia, or double vision. The other unique characteristic of Graves' disease is a type of infiltrative dermopathy, called pretibial myxedema. Excess accumulation of glycosaminoglycans cause swelling of the lower extremity dermis, giving the skin a waxy appearance. Almost like an orange peel. Kinda like those shiny leather boots. There can also be papules or nodules that are dark purple to yellow-brown. Pretibial myxedema is less common than Graves' ophthalmopathy, but definitely fair game on test day. On histology, there's significant hyperplasia and hypertrophy of the follicular epithelial cells and a predominantly T-cell lymphocytic infiltrate in the parenchyma. The cells become crowded around the follicles and even project inside as papillae. This is depicted by the pattern on her dress, with those dense cellular areas crowding and projecting into the light pink colloid. Overall, there's a reduction of colloid material as well, giving the existing colloid a scalloped appearance, as if it's pulling away from the parenchyma that surrounds it. Laboratory findings include a low TSH and elevated T4, typical of a hyperthyroid state. On radioactive iodine scanning, the gland will show diffuse uptake, giving it an overall hot appearance. Just look at that diffuse green glow. Not the safest working conditions down there, I imagine. Treatment of Graves' disease depends on the patient and the severity of symptoms. Most patients undergo definitive treatment with radioactive iodine ablation, which effectively destroys the gland, or surgery, which leads to subsequent hypothyroidism. In some cases, medical therapy is preferred, involving antithyroid drugs, such as methimazole or propythyl uracil and beta blockers. Check out our thyroid sketchy farm video for all the top secret deets. All right, time to wrap up this sketch with our last two important causes of hyperthyroidism: toxic multinodular goiter and toxic adenoma. These conditions are associated with thyroid tissue that functions autonomously, secreting excess thyroid hormone without any stimulus. Independently of TSH, in other words. Recall from the previous sketch that long-term iodine deficiency causes recurrent episodes of hyperplasia and involution of the thyroid gland, resulting in irregular enlargement and nodule formation. Just look at that guy, crumpled and beat up and bruised, and just all around nodular looking. Well, sometimes these multinodular goiters can start autonomously producing excess thyroid hormone. This is called toxic multinodular goiter, represented by our beat-up multinodular henchman who's having a change of heart, or maybe just snapped emotionally. Either way, he's running off with that T4 time bomb.
I've had it. With all this plotting, and scheming, conspiring.
Maybe he'll calm down.
I want to love!
No, he's gone. In many cases, the underlying cause of toxic multinodular goiter is a mutation in the TSH receptor gene that leads to continuous activation and release of thyroid hormone. Notice how he's ignoring the command of the tie-tightening TSH henchman who's trying to remain quiet. That controller ripped free from the hands of his superior represents a TSH receptor. And this time, it's acting on its own. Patients with toxic multinodular goiter will have the typical hyperthyroid pattern of low TSH and high T4. Nothing special. The results of radioactive iodine scanning, however, will be pretty distinct. Rather than the diffuse uptake seen in Graves', toxic multinodular goiter will show functional hot nodules. In other words, expect to see focal areas that uptake iodine, while other parts do not. It's especially concerning if there are non-functional or cold nodules, as they can be associated with cancer, as emphasized by the cold dead cancer crab gravestone. And lastly, toxic adenomas are solitary spherical nodules that also gain the ability to secrete thyroid hormone independently of TSH. Let that plus sign on the side of our next henchman's spherical and outrageously 60s headgear remind you of the ad in adenoma. And notice that the jetpack is malfunctioning and just kind of acting autonomously, raising that T4 into the air. Toxic adenomas are also often associated with a TSH receptor activating mutation. So again, we have another controller getting yanked out of the hands of that TSH tie-tightening crime boss. This represents a TSH receptor acting on its own. No TSH needed. Toxic thyroid adenomas are well demarcated and separated from the parenchyma by an intact capsule, represented by that helmet. Thyroid adenomas develop from the follicular epithelium, so they're also called follicular adenomas. In order to make the diagnosis of a follicular adenoma, it requires an excisional biopsy and evidence that the capsule is intact, as capsular invasion could mean that we have a follicular carcinoma on our hands. Check out our next video on thyroid masses if you can't take the suspense. Toxic nodules take up contrast on radioactive iodine uptake scanning, a good prognostic sign, as most hot nodules are benign. On the other hand, up to 10% of cold nodules eventually prove to be malignant. Remember that cold crab tombstone down there? So cold. These lesions will likely need further workup to exclude cancer. Treatment of toxic adenoma is similar to that of toxic multinodular goiter, with surgery or radioiodine. And just so we're clear, remember that toxic multinodular goiter started out as iodine deficiency goiter, while toxic adenomas have no relationship with iodine deficiency. All right, there you have it. Part 3 of our thyroid series, hyperthyroidism. First, we covered the clinical effects of hyperthyroidism, mediated mainly by a hypermetabolic and hypersympathetic state, leading to weight loss, tachycardia, sweating, palpitations, tremors, diarrhea, anxiety, all the feelings you might have at a graveyard at night. The most severe manifestation is thyroid storm, where you can have life-threatening cardiac arrhythmias, fever, shock, and even coma. The 3 big causes of hyperthyroidism that we covered are Graves' disease, toxic multinodular goiter, and toxic adenoma. Graves' disease is an autoimmune condition mediated by TSH receptor antibodies that stimulate the thyroid gland, leading to hyperthyroidism and goiter formation. A couple unique features are exophthalmos and pretibial myxedema. Look for the classic hyperthyroid labs, high T4 and low TSH, as well as diffuse radioiodine uptake. For toxic multinodular goiter and toxic adenoma, remember that these are conditions that involve autonomously functioning thyroid tissue. The pathogenesis may involve an activating mutation of the TSH receptor. No TSH stimulation needed. Look for localized radioiodine uptake in the toxic adenoma and irregular iodine uptake in the toxic goiter. All right, on to the malignant finale, thyroid cancer.